Hello, and welcome to the sixth Virtual Symposium of the Faculty of Medical Sciences at the University of the West Indies, St. Augustine campus, here in Trinidad and Tobago. I am Marsha Ivy, lecturer in public health and the Associate Dean for Public Relations at the Faculty of Medical Sciences. Today, I will be your moderator for this symposium on chronic non-communicable disease and the eye, in observance of World Sight Day, Hope in Sight. We welcome our one UWI family from across our 5 campuses, members of the general public here in Trinidad and Tobago and the wider Caribbean region, and those further afield. Before we begin the proceedings, we have a contribution from the Blind Welfare Association of Trinidad and Tobago.
Good morning, everyone. My name is Jaden Vincent. I am 14 years old and I was born with congenital glaucoma. This means that I wasn't able to see well. However, I currently attend the Davie Secondary School. I like programming and technology in general. So now that you know a little bit about me, let's begin to pray. Mr. Rogers, who loved all children, once said, "A part of the problem with the word disabilities is it immediately suggests an inability to see, or hear, or walk, or do many things that we take for granted. But what about people that cannot feel? People that cannot talk about their feelings, or manage their feelings in constructive ways? People that find no fulfillment or have lost all hope? People who live in disappointment and bitterness, that find in life no love, no joy. It seems to me these are the real disabilities." Stephen Hawking once said, "While there is life, there is hope." Supreme Being, hear your child. Bless this symposium as we commemorate World Sight Day. Bless this meeting of minds and hearts. Bless this communion of individuals, unique in his or her own special way, beyond the skin and hair that human eyes love to see. I pray for guidance and good counsel for my leaders and elders in the community of medical personnel and social workers that strive to protect the precious gift that is eyesight. I also pray that my leaders and elders in the community of blind and visually impaired persons continue to be blessed with vision beyond sight. Let the work that begins here today create a legacy and a future that we will all be proud to live in. Helen Keller once said, "The greatest things in life cannot be seen or even touched, but be felt with the heart." Supreme Being, I pray that the events of today touch the hearts of many. Thank you.
Thank you so much, Jadon. That's Jadon Vincent from the Blind Welfare Association of Trinidad and Tobago. Thank you for your contribution. So let us start our program. Our program on chronic non-communicable disease and the eye focuses on 4 areas, namely lifestyle, primary care, ophthalmic manifestations of NCDs, and treatment of eye diseases. This will be presented in 2 sessions by our 5 guest speakers, Ms. Theresa Pierre, Mr. Gabriel Jesus Mactier, Drs. Shastri Motilal, Kawaiwa Clark, and Shari Cadogan. The proceedings are hosted by Dr. Desiree Murray, lecturer in ophthalmology at the UWI St. Augustine campus. We will now have opening remarks from Professor Terence Simongo, the Dean of the Faculty of Medical Sciences, UWI St. Augustine. Over to you, Prof.
It is my pleasure to welcome everyone on behalf of the Faculty of Medical Sciences and to make a few brief comments. on this important day for ophthalmology in Trinidad and Tobago, which is called World Sight Day, and aims to focus global attention on vision impairment and blindness. There is a different theme every year, and I've been involved with this, except on the one or two occasions that I've been out of the country, every year. And I must commend Dr. Murray for the work that she has been doing in keeping it going every year. She has certainly shown great dedication to her profession, and naturally, I want to commend her for this. But globally, the International Agency for the Prevention of Blindness has a leadership role in preparing the annual World Sight Day. And as I understand it from Dr. Murray, the skeleton upon which today's presentation is based has come from the International Agency. World Sight Day is coordinated by this International Agency for the Prevention of Blindness, and it has become an official international day since the year 2000. World Sight Day is the focal advocacy and PR event for the International Agency for the Prevention of Blindness, and every year highlighting the fact that more than 75% of all blindness and moderate and severe vision impairment is avoidable. It provides a platform for organizations to encourage governments, corporations, institutions, and individuals to actively support universal access to health. And it is this drive that the Faculty of Medical Sciences is proud to be associated with. As I understand it, there are 150 member organizations together under the umbrella international organization. And it is thought to include every major eye care non-governmental organization in the world. The focus this year is on the chronic non-communicable diseases and how they affect the eye. And it is for that reason that the program is organized as you see it. So you will find that there are presentations from people completely outside of formal eye care professionalism. And I'm also pleased to note that two of our postgraduate students are giving presentations which have all been reviewed by their senior colleagues in the department. Cataract and uncorrected refractive errors remain by far the leading causes of vision impairment worldwide. However, several other eye conditions have emerged as significant threats to people's vision. Diabetic retinopathy, glaucoma, and something that is relatively new, age-related macular degeneration. These diseases all affect the back of the eye. What they have in common is that they are incurable and require ongoing management, unlike cataract or refractive error, for which surgery or a pair of spectacles can restore vision. Over the last 2 decades, these non-communicable eye diseases have become much more significant. That is diabetic retinopathy, glaucoma, and age-related macular degeneration. What is more, people are actually living longer. I can say that when I returned here in the early 2000s, seeing people over the age of 90 was an unusual thing for me, and now it is by no means unusual. It is clear that even in Trinidad and Tobago, where our average life expectancy is thought to be a bit low for the Western Hemisphere, we are seeing a lot more people in their 80s and 90s. And therefore, these non-communicable diseases become of greater significance, more so because maintaining Your eyesight is one means of maintaining independence as you get older. Prevention and early detection of these diseases is of utmost importance. Awareness campaigns and screening is essential. Patients also have to understand the value of managing incurable diseases if they want to protect the vision that they have left. In most first world countries, comprehensive eye care services for the prevention, early detection, and management of these diseases are quite successful. In the third world, far less so. In a national guideline for the prevention of blindness in South Africa, the Department of Health reported a 0.75% prevalence of blindness in that country, of which 80% of these cases were said to have been avoidable. 80%. We at the Faculty of Medical Sciences spend quite some time training our students over the 5 years in the pathology of eye disease and then the management or initial management of eye diseases. An important technique that is easy to do and can be done in an emergency and at the bedside is fundoscopy, which all our graduates are trained in. And this is very important in detecting early diabetic retinopathy. The impact of vision loss is measured in the form of disability-adjusted life years. Although people with vision loss are still alive, they can have severe disability due to preventable or treatable blindness. Of all the senses, sight must be the most delightful, as Helen Keller once said. Vision loss steals your independence and can take away your joy of life. Many people believe that blindness is not preventable and is simply part and parcel of normal aging. However, programs that target blindness and the conditions that cause it can change the lives of individuals and improve public health nationally. You are going to hear a lot more about preventive measures. But as a pulmonologist myself, I can tell you, quit smoking is a very important one for general health, but also for eye care. Maintain a healthy weight. Make healthy food choices. Reduce completely, or perhaps a little less pleasantly, cut sugar from your diet. Very importantly, stay active and move every day. You're going to hear a lot more about this as today's program unfolds. I don't want to steal anyone's thunder, but I do want to thank all of you for coming to participate. And importantly, I want to thank our presenters for the important information that they will be conveying to you. And feel free to be as interactive as possible during the question and answer session.
Thank you, Professor Simongal, Dean of the Faculty of Medical Sciences, St. Augustine Campus. And now we're going to have an overview of World Sight Day from our host, Dr. Desiree Murray. Dr. Murray is a lecturer in ophthalmology at the University of the West Indies, an honorary consultant ophthalmic surgeon at the Port of Spain General Hospital in Trinidad and Tobago. She trained as an ophthalmologist at the Birmingham and Midland Eye Centre, UK, where she undertook fellowships in both vitreoretinal surgery and glaucoma. She also holds a master's degree in public health for eye care from the University of London, the London School of Hygiene and Tropical Medicine. Dr. Murray practiced as a dual specialty vitreoretinal and glaucoma consultant for 6 years before focusing her attention on the prevention and avoidable blindness from glaucoma. Desiree is the co-founder of the West Indian Society of Glaucoma Surgeons and co-founder and sitting chairperson of the Volunteers for World Sight Day, an NGO which raises awareness about the prevention and avoidable blindness. We hand over to Dr. Murray.
Thank you, Marsha, and thank you, Professor Simongal, for opening these proceedings and for your kind words and support for work towards blindness prevention. As you pointed out, most people cherish sight above all other senses. The call to action for World Sight Day 2020 is Hope in Sight. Eye care professionals are refusing to let 2020 be usurped by the coronavirus. Hope is defined as an expectation of a positive outcome. The second wave of COVID-19 should not bring with it a tsunami of chronic non-communicable diseases, NCDs. Quarantine, lockdown, and physical distancing due to COVID-19 should not prevent us from making healthy lifestyle choices. A healthy diet and regular exercise go a long way towards preserving eye health and preventing avoidable blindness from NCDs in the region. To this end, this symposium is not only a collaboration between the Department of Clinical Surgical Sciences and other departments within the Faculty of Medical Sciences at the St. Augustine campus. It is also a collaboration among the UWI campuses and between the University of the West Indies and external organizations such as the Board of Nutritionists and Dietitians and the Ministry of Sport and Community Development. Most importantly, this symposium is a collaboration between your university and you, the Caribbean people. The 2007 Declaration of Port of Spain, uniting to stop the epidemic of chronic NCDs, resulted in a historic and unprecedented effort by heads of governments of the Caribbean community who recognized the devastating burden and consequences of non-communicable diseases such as diabetes and hypertension on their citizens and the need for an all-inclusive response. At the University of the West Indies, we are proud of our reputation as a first-class global institution. This symposium addresses one of many important roles of the UWI during these challenging times in this era of COVID-19. As our Vice Chancellor has said, the UWI has its sleeves rolled up. It is said that to live without hope is to cease to live. The expression, no hope in sight, means that all is lost and we are doomed. But when we say hope in sight, we are expressing optimism for a brighter tomorrow. We hope for guidance, we hope for wisdom, and we hope for health and strength to continue our efforts to eliminate avoidable blindness. There is hope in sight. Thank you.
Thank you. Thank you, Dr. Murray. Thanks for giving us that brief overview of World Sight Day and having hope in sight. Our first speaker for the next session, session one, is Ms. Teresa Pierre, who is a registered dietitian and the Chief Executive Officer and owner of Bite and The Body Talks, which she founded in January 2007. She's the holder of a UWI Bachelor of Science in Human Ecology and a postgraduate diploma in Institutional and Community Nutrition and Dietetics. At present, Ms. Pierre is the Secretary of the Board of Nutritionists and Dietitians, holding the post from 2019 to 2021, and has also served as an executive member of the Trinidad and Tobago Association of Nutritionists and Dietitians, 2013 to 2014. Ms. Pierre will now share with us on nutrition in the era of COVID-19, establishing and maintaining a healthy diet and dietary supplements. Over to you, Ms. Pierre.
Why, thank you so much, and good afternoon to the listening audience, the viewing audience as well. Excited to be able to share on this establishing and maintaining a healthy diet during the COVID-19 pandemic. But let's look at what has been happening with this pandemic. We have Harvard tracking the numbers for us, and they have said that they are, as of today, actually, I did check, 35.9 million persons globally with the condition, and that's 1.05 million persons. But to be honest, the conversation about NCDs, deaths, and before the pandemic has also highlighted millions of people who have passed which with conditions that are preventable, let's say. And when I say preventable, it's important to understand that a non-communicable disease in most instances, such as cardiovascular disease, hypertension, strokes, cancers, diabetes, the chronic respiratory diseases, most of them, if managed well, using these two categories of risk factors, the non-modifiable, which of course we can't do anything about, it speaks to your age, your gender, and your family history, but the modifiable risk factors are what we want to be able to be aware that we can do something differently in terms of unhealthy diets, physical inactivity, excessive use of alcohol, and tobacco use. Some food for thought here. Professor Christopher Kuzawa of the Northwestern University of Illinois. I read this study and he had done it in 2012. And the study suggests that a mother's diet as an adult had an effect on the baby's birth weight. Far more important with the mother's health and nutrition as a baby and toddler, and even the grandmother's diet when she was pregnant with the baby's mother. The work raises the prospect that a person's health at birth is governed by a long history of health and nutrition going back more than a generation. So that when we speak of lifestyle changes, diet, and physical activity, it is about preserving the generations to come, something that might have been said before, spoken of, but not really embraced. So that even as Dr. Murray had mentioned, 2007, when our governments came together, this was the trend, this was the thought, this was the intent to change lifestyles and diet and physical activity. So what I have done is really held on as a dietitian to this new normal conversation. And this is what I pitch for my clients in terms of the lifestyle changes that have to come when they're reducing risk factors, ceasing smoking, reducing sodium intake, reducing trans fats, and with replacing your trans fats with polyunsaturated fats and managing your weight, being more physically active daily. So that when we have to establish a healthy diet, you will go through a process where diet history is taken, your anthropometric data is assessed, your meals over 24 hours or 3 days are assessed, and your caloric intake is calculated. Nutritional needs also depends on your age, your sex, your weight, your height, level of physical activity, stage of the life cycle, the body size, and your general state of health. Eating healthy, let me say this, is more than just eating what is good for you, which is something that is a buzz phrase that we oftentimes hear. For it's more than that, since its serving sizes are important. It also involves using your calculated dietary caloric intake, which is distributed among measured servings for the day. Macronutrients are also important. So we have to look at the carbohydrate content and the ranges that are used. For some diets omit these. The amount of protein, some diets go in excess of the recommendations, and the amount of fat, which also could be exceeded. So just to give you a little bit of visual here, we have some of the actual food models, and I actually do use these in my practice when I do. So you have your group of staples, and each one represents a specific serving size. Your legumes, peas and beans and vegetables, your fruits, and understanding there is a benefit to having a high fiber diet that makes you feel more satisfied, for better blood sugar control, since the emphasis here a lot would be on diabetes, as the fiber takes longer to digest, less cravings as the day progresses, and carbohydrate is one of the first nutrients that the body may use as fuel for your activity. The changes in your blood level glucose are also important. Understanding that with a carbohydrate-rich meal, there is a response in terms of insulin and glucagon. But as you maintain a healthy diet, do not treat excessive eating with medication. That's something we oftentimes do, or exercise. I will eat this and I will burn it up, or I will take my medication. Try not to snack on those staples like your breads and biscuits. Always prepare to have different types of snacks like your fruit, your legumes, your milk-based options as snacks, and avoid grazing, which is something that you find happening with the COVID lock-in. People are grazing, they're oftentimes opening the refrigerator. Be careful not to fall in that young bird syndrome, where you can say, I can eat anything that comes into the nest. We've been trying out several recipes during this time. It's important to take control of your environment and be wary of the contents of care packages that might be high in sodium. Self-manage to improve your glycemic control, to keep track of your A1C if you're diabetic, or even if you're not, you don't want to fall into that category, and testing regularly. Supplements are important, but the FDA has a position where they say that supplements can be beneficial, but they can also involve health risks. They're not an authority on it, so they leave it up to the manufacturers, and some of the claims that are made should not be made. A healthy immune system eliminates the need for supplements, so it's important to do that. And before using your supplements, a balanced diet that will provide the RDAs that you need are important. Consult your physician, disclose all supplements and over-the-counter drugs, and you understand that there is no evidence that vitamins and minerals has any effect on COVID-19. Vitamin C is one that is very popular. C and D, B, and zinc, garlic, and selenium in terms of managing the common cold and probably COVID. So just to remind you, be aware that some supplements may interact with prescription and over-the-counter medication, and that some of the effects can be life-threatening. But if you look at warfarin, if you're on warfarin, ginkgo biloba, aspirin, vitamin E are some of the blood thinners that you would want to recognize that all of them may do the same thing, and you will have to let your physician know before you explore these. So I just wanted to remind us that we eat to live or die, because that's how powerful food chemistry is. Thank you so much.
Thank you. Thank you so much for that, Ms. Spear. Thanks for kicking off the lifestyle section and highlighting the importance of maintaining a healthy diet and paying attention to the nutrients that or nutritional content and being wary of those care packages. So we're going to move on to the next presenter in this lifestyle section. But first of all, ladies and gentlemen, I just want to remind you that at the end of this first session, we're going to be taking your questions. So please start popping them into the chat forums of UWI and Facebook Live. And we will put them to the presenters at the end of this session. So our next lifestyle presenter is Mr. Gabriel Jesus McTeer. Mr. McTeer commenced his studies in sport with a certificate in the art and science of coaching at the University of the West Indies, St. Augustine campus, and progressed to complete his Bachelor's of Science degree in Physical Education and Sport at the International School of Physical Education and Sport in Havana, Cuba. He furthered his studies with a certificate in sport marketing and management and a diploma in sport psychology, as well as a diploma in therapeutic massage. He's currently completing his master's in sport for development at the University of Trinidad and Tobago. Presently, he's employed with the Ministry of Sport and Community Development as the Acting Assistant Director of Physical Education and Sport. Mr. McTeer will now speak on physical activity in the era of COVID-19. Mr. McTeer, the screen is now yours.
Thank you very much, and a very good afternoon to the viewers or the presenters as well. And I am always very happy to be able to have the opportunity to speak on physical activity in general. And considering that we are in this pandemic, it's good to provide some knowledge as to how we can maintain physical activity in the era of COVID. And as we go along, first and foremost, the negative effects of COVID on physical activity. Number one, you have the closure of gyms and public spaces for exercise due to government restrictions. There's, of course, the inaccessibility to fitness equipment. And there's a lack of motivation, especially when it is you have to be at home a lot. There's usually a lack of motivation to just get up and move. Of course, there's that fear of going outside, of being in public spaces because you don't want to come into contact with the virus. And of course, for those who like their sweat, whether it be football or basketball, and so team sports are not being encouraged right now. The problem that exists with these negative effects of COVID would naturally be one, there's an increase in sedentary behavior coupled with poor diet, as would have been discussed prior in the previous presentation. Also, there's that increased risk of developing lifestyle diseases, being obesity, hypertension, diabetes. There's the development of irregular sleep patterns. A lot of people spend very much time either on their phone or their television sets, their tablets, and that in itself tends to affect the ability to get proper sleep, especially if it is you lie down just before sleep time with these devices in front of you. All of this tends to lead to a compromised immune system, which in essence makes you more susceptible to contracting COVID-19 and other viruses as well that are still around, whether it's H1N1, the common cold, etc. And there's also the mental aspect of this whole COVID-19 pandemic. There's a likelihood of developing depression, anxiety about the disease, and possibility of either yourself or your family member contracting it, and other mental health issues that relate. In terms of solutions towards exercise during the COVID pandemic, one thing that can be done, create and dedicate a space in and around your home where you can exercise. You could also search out less populated open public spaces. I mean, open air basketball courts and recreation grounds tend not to have too many people engaging in sport and physical activity. So maybe if it is, you can find a particular time frame that is quiet. You can utilize that to get your exercise in. Establish a daily schedule and try to fit in 30 to 45 minutes of exercise during that time. Have an exercise buddy for motivation, someone that you could physical distancing protocols, but then also somebody could just call you, just give you a phone call and say, hey, at this time, this is exercise time, come on, get up and go. So those things tend to help. Utilize online facilities for exercise. There are a number of apps and online workout sessions that exist from various gyms and fitness instructors. And YouTube also has a plethora of workouts for beginners if it is you're not that experienced with exercise, and also for the advanced persons as well. Your body, remember that your body is an excellent piece of exercise equipment. There are so many exercises that you can do with just your body weight. You can utilize items around the house as well as exercise equipment, being cans of food, bottles of water. You could fill bottles with gravel or little pebbles, and so to help increase the amount of weight used. And also, this might be the time as individual sports are given more preference when it comes to health restrictions from the government. Might be the time to learn and engage in a new individual sport. Yeah? Tennis, table tennis, badminton, etc. Now, yes, as it relates to exercise and eye health, it's important that we understand that when we talk about exercise, it's not just with respect to non-communicable diseases, but as we are specifically within the celebration of World Sight Day, understand that there are several studies within the last 10 years that have found connections, very positive connections between regular exercise and reducing the risks of several common eye ailments, being cataract, wet age-related macular degeneration, diabetic retinopathy, and glaucoma. Cardiovascular exercises such as aerobics will help to lower intraocular pressure or the pressure in the eye, and also cardio exercises, also increase the flow of blood to the optic nerve and the retina. Vision problems and eye diseases also stem from high blood pressure, high cholesterol, and type 2 diabetes, which can be counteracted by regular exercise and, of course, a healthy diet. And specifically to the eyes, while we talk more about exercise in terms of the skeletal muscles, there are specific eye exercises that can be done to ensure that the eyes stay healthy. Okay, so this is just a bit of an example of that. And some things to just note and remember very quickly. One, excellent workouts can be achieved in limited spaces. So even though you might not have much space in your house, you have outside, all right, and even within a living room, there are a number of exercises that can be engaged to help strengthen your body and increase your cardiovascular strength, right? And it can be done with very minimal equipment as well. Treat your fitness development as a journey to your best self. There needs to be a positive spin sometimes on being able to ensure that you get your fitness done, even though you may not necessarily want to. It's a journey. Work on it as best as you can because it will benefit you. Engage in a lot of self-talk. That definitely helps. Trust me, I know, right? Bring friends into the process for motivation. As I mentioned, the fitness body also helps in that regard. Embrace and enjoy the challenge of exercising in a different way and in a different environment. Some people are accustomed going to gyms. This is a way to sort of switch things up a little bit. Enjoy the process of being consistent and reward yourself for consistency. And always remember that in terms of recommended amount of exercise, 30 minutes of moderate intensity exercise at least 3 times per week is excellent for general health and, of course, for the maintenance and improvement of eye health. And just a little bit of motivation, so to speak. I just wanted to kind of touch on this video very quickly. I'm not going to spend very long on it. Enjoy.
Meet Naomi Rogers, the 101-year-old super granny, to those who know her, where she works out at the Duro Body Gym. While some of us younger folk may make excuses about keeping healthy, for Miss Rogers, that excuse does not exist where her health is concerned, even long after retirement.
They say from time immemorial, I always tried my best to keep on the healthy side. And to do that, you have to pay much attention to the things you eat, your rest, and exercise. Those contribute to good health. And I engage in those things since I was a girl.
For this warrior, being able to make it to the gym is surprising even for her, but it's something she enjoys. Well, she had this message for Trinidad and Tobago.
Nourish your body well. Get enough rest because those are the things that are necessary. Good food, rest, exercise. The resting part.
All right. So I'll end the video there for now, but just to give you a little bit of inspiration and motivation at still alive and at 102, she still exercises regularly. All right. So always remember, your body was created to move, but it won't unless you willingly move it. Thank you very much for your kind attention, and I'm open to questions when that time arises.
Thank you very much, Mr. Max here. That video at the end certainly summed up everything, summed up both your nutrition, rest, and exercise. Very important. We're now going to move into the second segment of the first session, which is going to look at primary care. And we're going to be doing that with Dr. Shashri Motilal. Remember, we'll be taking your questions right after his presentation, so remember to pop them into the chat on Facebook Live and UWI. Dr. Motilal is a graduate of the University of the West Indies, St. Augustine campus. He has been a lecturer in family medicine with the Faculty of Medical Sciences, UWI, St. Augustine campus for the past 8 years. He is a practicing GP, family doctor, for the past 14 years and trains doctors specializing in family medicine as well as medical students. He has interest in minor procedures in the GP setting and enjoys and hydroponics as his hobbies. We now invite Dr. Motilal to speak to us on primary care in patients with chronic non-communicable diseases. Over to you, Dr. Motilal.
Thank you very much, Ms. Ivy, for that introduction. Good afternoon to all our viewers out there, and special thanks to the organizer of the symposium for inviting me to speak. The objectives for my little talk today, we'll be looking at a few things. We'll say something about the non-communicable diseases in the Caribbean. We'll say something about how to prevent the NCDs and their complications. We'll look at some of the treatment targets for some of the common NCDs. We'll look at how NCDs have been impacted by COVID-19 and what are the options for continuity of care. And we'll say something about primary eye care, some common facts and myths about the eye. So just to emphasize the point that was already raised by the previous speaker, if we look at what's causing most of the deaths in Trinidad and by extension in the Caribbean, the majority of the deaths that we see are accounted for in this red section in this graphic. As you can see, diseases of the cardiovascular system, hypertension, heart disease, diabetes, and cancers account for more or almost 2/3 of the deaths that we experience in Trinidad. So when we talk about these chronic diseases in the Caribbean, we have all heard them before. Heart attacks, stroke, diabetes, cancers, leading cause of premature death. According to surveys conducted in 12 CARICOM countries, up to about a quarter of adults have diabetes, and up to almost half of adults suffer from hypertension. Now, those are scary statistics. What are the symptoms of chronic disease? While many persons can develop symptoms from chronic disease later on in the disease, what I want to emphasize on this slide is most often in the early stages of all the chronic disease, people experience no symptoms. For example, in a survey done, half of the people in Jamaica did not know that they have high blood pressure. 25% of persons who are diabetic do not know they have diabetes. And 80% of persons who have high cholesterol do not know they have high cholesterol. These are scary statistics to me because what it means is that the only way to detect these conditions really is to test for them. And unless you are testing, you can actually have all these diseases, which we all know can be silent killers. So is there hope? We heard extended definitions of this word. And of course, I'm here to tell you, yes, there is hope. Screening. The concept of screening says we take a person who's completely fine and healthy, not experience any symptoms, who may have a chronic disease, and we get them tested. So what we encourage is patients to visit their GP, their health center, get yearly tests done for sugar, for cholesterol, and have their blood pressure recorded. And of course, there is also treatment. If we look at the treatment of the non-communicable diseases, they can fall into two categories. The first one is lifestyle, and we have heard excellent advice from the previous two speakers on how we can use lifestyle to actually prevent and treat these diseases. What I want to emphasize here, though, on this slide, is sometimes we only think about following healthy lifestyle when people get diagnosed. I have lots of patients, I tell them they're diabetic, and then they ask me, so doc, tell me how to eat. The truth of the fact is that we should all be eating healthy even before we get chronic illnesses. It could actually prevent chronic illnesses. So lifestyle measures are not only for persons who have chronic non-communicable diseases, it's also important to prevent these diseases from coming on. And of course, the other aspect is medication. Taking your medicines, using your insulin, your pills, taking them as prescribed by the doctor, monitoring your blood pressure and sugar levels as advised by the doctor. This is very important. Often I see lots of patients with chronic non-communicable diseases, diabetes, hypertension. I ask them, what medicines are you on? Most of them don't know the name of the medicines. They're not even sure exactly how they're supposed to take it. So what are the targets? A person has diabetes or hypertension or high cholesterol. There are a few targets that we like to encourage them to accomplish. The first target for diabetes is this thing called the HbA1c. When I say this to patients, again, patients say HB who? What is that? HbA1c is a 3-month average for your sugar level. All patients who are diabetic should do a HbA1c on a regular basis to track their diabetes. The magic number, generally, most doctors advise, is less than 7%. If your sugar is less than 7% your HbA1c, we generally say it's well controlled. If it's more than 7%, I usually say to patients, you're in the red. Fasting blood sugar for persons who have to monitor the sugar by sticking their fingers at home should be less than 100. 2 hours after a meal, which is sometimes a measure that people sometimes forget to sometimes check, should be less than 180. How about hypertension? Blood pressure generally should be less than 140 or 90. There are some specific targets that sometimes doctors may advise where patients may have to go a little bit less than this, but generally saying your blood pressure should be less than 140 or 90, of course, for adults is a good general target to abide by. And of course, how about cholesterol? Generally, we want the total cholesterol levels in the blood to be less than 200. We want the good cholesterol, the HDL cholesterol, to be more than 40. So what about COVID? This is something, of course, very topical these days. How has COVID affected chronic disease care? COVID has definitely affected chronic disease care, but of course, there is hope for patients with chronic diseases, even in the light of COVID. So what some clinics I'm aware of have been doing is they've been trying to, of course, maintain social distancing in clinics by doing block appointments. So if they have 60 diabetic patients to care for, at 8 a.m. they bring in 10, at 9 a.m. they bring in the other 10, and so forth, so at least to maintain social distancing. So appointment systems have had to be modified. How about convenience and safety? Some clinics are also encouraging telemedicine. Telemedicine can range from something as simple as picking up the phone and talking to a patient, or something like what we are doing now, doing an actual teleconference. Telemedicine, of course, makes it very easy to care for patients with chronic disease and provide vital advice right from the safety of their home without having even to walk into a clinic. Availability of medication. Some patients get concerned that they're not able to visit the clinic to collect their prescriptions. And what some doctors have been doing is after the telemedicine consultation, if their prescription needs changing or editing, they would do it accordingly and have the patient or relatives come in on their behalf to collect the prescription. And of course, it doesn't mean that even in the face of COVID, patients are not getting face-to-face care with their doctor. Definitely some patients need to come in physically to see the doctor because they need examinations done. And of course, that could be facilitated even in the COVID-19 pandemic. So I'll say something about eye care now as it relates, of course, to the symposium. And the first thing I want to touch on is the levels of eye care. Generally, health in general are delivered in different levels: primary, secondary, tertiary, and eye care is no exception. Primary eye care is this broad concept encompassing the prevention of potentially blinding eye diseases through primary health care. And this contrasts with secondary and tertiary health care for the eye, which involves seeing about people when they get injuries or develop symptoms, and referral for more specialized services, like if patients need life eyesight changing surgeries and interventions done. Primary eye care, of course, involves several things, and I'm involved in primary eye care to a certain extent as a GP because I do some of the things in keeping with primary eye care. I check visual acuity, measure person's vision. I deal with some common conditions. If I identify serious problems, of course, I would give timely referral to the specialists. We prevent complications to the eye through promoting lifestyle and treating the chronic diseases that we heard about so far, screening, and of course, education. Just to emphasize the point though, that when we say primary eye care, it's not only a physician involved, there are many other members of the primary eye care team that actually is important in delivering primary eye care. And just to name them, of course, the patient is central to all of this: nurses, the ophthalmologists, the optometrists, and the opticians. These are all very important people, equally important when we deliver eye care. So I said one of the points in my presentation that we do as GPs is education. So what I usually like to conclude my little talk with is with some common facts or myths. So as I show these statements on the next couple of slides, I just have 5. I would like our audience at home just to think about the answer, think if it's true or false as we go through. So here goes. Wearing glasses makes your eye dependent on them. So the answer to this one is it's false. Wearing glasses makes your eyes dependent on them is false because your eyes do not get addicted to glasses, but you may simply need them to see better and would require that your prescription change over a period of time. Second myth or fact: sunglasses are the best way to protect your eyes from the sun. What do you all think? So some persons are of the belief that once they wear glasses of any sort, once it's dark, it would necessarily protect your eyes from the sun. So don't assume that wearing a dark glasses will necessarily keep your eye safe. What you should make sure is that the lenses in those glasses are able to filter out ultraviolet light. Ultraviolet light are the rays that are actually harmful and damaging the eyes. Blindness from glaucoma can be prevented. This one probably is an easy one because the answer for this one is a resounding yes. Blindness from glaucoma can be prevented, especially if glaucoma is diagnosed early enough and persons are given appropriate treatment. Another common one, you have to wait till a cataract is ripe before it can be removed. Patients have asked me this. The answer to this one is, it is false. Not all cataracts affect visions adversely. Sometimes you visit your ophthalmologist and they see a tiny cataract in the eye and the person says, well, I'm seeing okay, but it's a matter of quality of life. Usually we operate on cataracts and do the surgery when the cataract starts affecting vision to disrupt a patient's quality of life. And the last one I have, reading up to the last line on that vision chart means your eyes are perfectly healthy. Most of us have probably been assessed and we have been asked to do this visual acuity test where they ask us to read the letters and we reach up to the last line and we say, yes, my eyes are excellent. I've had my diabetic patients tell me this. Well, a bit of disappointing news. Just because you could read up to the last line in your eye chart doesn't necessarily mean your eyes are perfectly healthy. It means you have good central vision, but having 20/20 vision, it's possible, but you can still also have diseases like glaucoma and diabetic retinopathy, which we'll hear about later on in this presentation. And with those quick facts and myths, I thank you very much for the presentation and for listening.
Thank you very much, Dr. Botila. Thank you for taking us through those points on primary care in the eye, as well as for highlighting some of the risk factors and some of the things we need to pay attention to and changes we need to make, especially at the end, the myths and the facts. Yes, we all get confused with those sometimes. Thank you very much, Dr. Motilal. Thank you to all the presenters in this section. And ladies and gentlemen, we're now going to move into a 15-minute Q&A segment just to take your questions and get the presenters to feedback for you. So just use the chat forums and pose your questions and we'll try and take all of them. The first question, which comes from UWI TV website, and this goes to Mr. Mateer. There is an exercise culture where persons exercise collectively as it helps with motivation. There are also many sports that require physical interaction. How can we overcome these considerations other than home workouts?
Now, the first and foremost thing is that you can still exercise in a group, a small group, in public spaces, at least according to the restrictions now. So I guess first and foremost, what we have to do is to go along with whatever the government would provide as the restrictions or the allowances when it comes to social distancing, when it comes to congregating more so. So I think that's the first thing. You need to be aware of what is allowed. Secondly, if it is you have to do it at home, and you're not able to go out and you want to exercise in a group, it's still a matter of utilizing a yard space if a yard space is available, or if it is you have some sort of open area nearby that you can exercise, that should be amenable to you and the group. Of course, it's very important to maintain the size of group in accordance to the government restrictions. So if it is, I think as it is right now, we can't go more than 5 persons congregating, then you maintain that 5, but of course maintain the physical distancing that is required. If it is, let's say you have a large enough space at home in a gallery or a porch, as we tend to call it sometimes in Trinidad and Tobago, if you have that sort of space, that offers an area whereby you can train at home with your group and get exercises done. And either hopefully you have persons who have experience in exercise, or you, again, as I mentioned, you could utilize YouTube, you could utilize apps or online sessions that gyms will provide to be able to engage in safe exercise.
Thank you, Mr. McTeer. The next question goes to Ms. Pierre. What is the difference between portion sizes and serving sizes?
Right. This is a topic that sometimes people ask simply because they misinterpret and use the terms interchangeably. A portion is really 100% up to your control. So that when we talk about serving sizes, we talk about specific quantities, whether it's a half cup, 2 tablespoons, and so on. And when you read food labels, they will oftentimes indicate on the package what the serving size is and how many servings are there in this particular product. So that portion sizes, if you were offered one small pawpaw, your portion could be the entire pawpaw. When in fact, a serving size of that particular fruit will be just half cup of cubes. So that when you begin to delve into portions and serving sizes, if you're going to do it in context of managing the amount of calories that you take per day, serving sizes are what you need to focus on in terms of getting the right amount of calories, because attached to each serving size is a calorie count, and understanding that if you just particularly go with the portion that you think is adequate for you, you could very well be overeating, having more than is necessary, and it really becomes a concern, especially if somebody is diabetic and managing good blood sugar control. In the food category, if you're managing your weight for fats and so, understanding that one serving of avocado could be just this, what we call a slither sometimes, but this is 1 ounce and this is 45 calories. And in our culture, people normally they look at this with scorn most of the time, and they will have a portion, not a serving size.
Thank you. Thank you, Ms. Pierre. As you put up that demonstration, it made me think about what I would have. Thank you, Ms. Pierre. Another question to you, Ms. Pierre. Are fresh vegetables better than frozen vegetables?
Okay. Fresh and frozen, in terms of calories, no major difference there. Of course, fresh would be best in terms of the bioavailability of the vitamins and minerals in the particular product. Frozen oftentimes are necessary because it still gives different populations who may not have the opportunity to get at fresh, the opportunity to get their vitamins in. So that it is smart to suggest both options when you're dealing with clients, because you don't want people to think that if it's not fresh, it is not good. That is not the case. You still want to be able to say, yes, I have been able to have my portion of vegetables, which will give me the right amount of vitamins and minerals and so on. Because when they freeze vegetables, sometimes they might freeze dry them, or they may do what we call blanching, so that it inactivates the enzymes in them to avoid decay and deterioration. So you can go either way. If you can go fresh, that's best, as we would say. But even frozen is an option in terms of getting your regular, at least 3 servings, let me say, of vegetables for the day.
Thank you, Ms. Pierre. The next question from UTV goes to Dr. Motilal. Dr. Motilal, a viewer would like to know, what role could community healthcare play during COVID-19 to prevent potentially jeopardizing our primary healthcare institutions?
So that's a very interesting question. Thanks for that question. It's a difficult thing to answer. It depends really on what phase we are in the epidemic or the pandemic. It definitely has a role to play in the sense that a lot of the conditions that we see that affect most persons are being treated at the level of the community in the health centers and the health systems. And I think it's probably most important to ensure that patients still get screening and preventative advice, and they're still able to get the basic care that they need. So I think definitely advocating for community care and primary care makes a huge difference in this time of the pandemic, because those patients are sometimes the more vulnerable groups. Those are the ones who, if they don't get their medications or they don't get treatments, are likely to deteriorate and feel ill. So their role is definitely important.
Thank you, Dr. Motilal. And another question to you, Dr. Motilal. You mentioned screening. Who should really screen for conditions such as hypertension, diabetes, high cholesterol? Who should screen for those conditions?
Yeah, so that's another good question. And I often have adults who ask me, can I go for a sugar test or a cholesterol test? I've had 20-year-olds ask me that question. I've had 60-year-olds ask me that question. The answer is we screen persons who we believe at risk. So if we're looking at diabetes and high cholesterol and hypertension, the easy, quick answer is if you have any one of those other conditions, you definitely should screen. So even if you have a person who's 30 years old and they have hypertension, we should test them for the other conditions. Definitely, we screen all adults over the age of 40 for these conditions, and we screen persons with risk factors. For example, if a person is obese, so a person might be 25 years and be obese, that person should be screened for diabetes, hypertension, and blood pressure as well. So in short, it really depends on your risk factors. Most adults over the age of 40 get screened generally, but younger persons do qualify for screening if they have risk factors.
Thank you, Dr. Motilal. Mr. Mactier, question to you. You did mention that viewers can use the apps online and videos online to do their exercises. In terms of the safety of those exercises, is there anything that viewers should be aware of in terms of maintaining their safety when using these unsupervised activities?
Sure, thank you very much. The main thing that you have to look forward to or look towards in terms of maintaining safety is, first and foremost, knowing if you yourself may suffer any conditions, any pre-existing conditions, or you may have any injuries that may limit your movement, limit your range of motion, and also mean that you have to be a bit cautious in terms of the intensity of exercise. It's first and foremost always advised that before engaging in any exercise program that you consult with your physician, just to ensure that you do not have any underlying conditions that may be exacerbated because of the intensity of exercise or any particular movements. If it is you are clear for exercise, then the keys are really to follow the movements that are done, and normally the exercises that are put forward in beginner, and that's why I sort of specified for persons who don't have much exercise experience, follow beginner videos on exercise so that the workout should be a lot simpler, the movement should be a lot simpler as well, the intensity would be lower, and that way you would be able to move along with what is being presented in the safest possible fashion. Other things to note, you want to have, usually in terms of stability of your body, you want to have your feet at about shoulder width apart or just over shoulder width apart for most exercises where you are static. And any exercise where you are bending, you want to make sure the back remains flat. And if it is you have to lift anything from the floor, you also want to make sure that you lift, as they say, lift with the legs or lift with the knees. All right. So those are some basics in terms of understanding how to function. If it is you're going to be using apps or using YouTube videos for your exercise routines.
Thank you, Mr. Mactier. So consult with your GP. So we're going to go across to the GP, Dr. Motilal, and a question to you. How often should patients with diabetes check their eyes?
Okay, yeah, excellent question. So, I mean, we'll hear this a little bit more about this probably from the other speaker in terms of how diabetes affects the eye itself. But generally, patients should be screened for what we call retinopathy. And when we screen patients for retinopathy, it involves they having an examination, a thorough examination of the back of the eye. The guidelines recommend that all diabetes type 2 diabetics, especially when they now get diagnosed, which are probably the majority of the diabetics we have in Trinidad, type 2 diabetics. The guidelines say that upon diagnosis, they should be screened. And how often we screen them after that really depends on the initial finding. Some patients who get diagnosed with diabetes, up to 1 in 3 of them, or 30% of them, going to have some evidence of eye disease when we examine their eyes. How often we screen them thereafter would actually depend on the exact findings. If the findings we see are really not vision threatening or not severe, sometimes you could screen them in longer intervals, every 6 months or up to a year. If you see some serious stuff going on, they may get treatment and need to get examined much more frequent than that. So it really depends on what is seen upon the first screening, but generally the first screening should be done at the time of diagnosis when most patients get diagnosed. Of course, there are other groups that should be screened appropriately. Pregnant patients who had diabetes from before need a little bit closer monitoring because their eye disease could worsen, so they may need more frequent screening. And type 1 diabetics persons, these are traditionally the children from early on or teenagers who get diabetes. The recommendation is they get screened from 5 years from when they were diagnosed.
Thank you, Dr. Motilal. And we're going to take the last question from UETV, and this goes to Ms. This goes to Ms. Pierre. So Ms. Pierre, the question that's being asked by a viewer is, given the threats of lockdown, the dangers of interaction, and the potential disruptions to trade, how seriously should we consider promoting growing foods at home given the COVID-19 threat?
Food security is extremely important. Having things available reduces the amount of anxiety, especially if someone is treated with something like diabetes and they are on medication. It is necessary for them to have that kind of balance so that their blood sugars don't go low, that they have the variety in the meals in terms of fruit, fresh fruit and vegetables. So as far as possible, where you can help, even with short-term crops, to supplement and make sure that you get what is necessary in terms of the vegetables and fruits, or even if you have to purchase, that goes a long way in terms of reducing the anxiety as to, I'm diabetic, but I can only have meats, I can only have foods from animals, I can only have rice or bread or so. How do I then get these other things? The thing, sometimes too, what is important to understand, and I will always say this again, serving sizes are important. So sometimes we find ourselves having the opportunity to get a pumpkin, a whole pumpkin, and then we would say, okay, it's pumpkin season open so that I can have as much as I want because pumpkin is good. Serving sizes are important, right? So that you would recognize that the pumpkin, even though it is your vegetable of choice at the time, it is a naturally sweet vegetable. The serving size is just about a half cup. And of course, we always use our measures when we are counseling. So a half cup measure is just about this. Sure, if you can see it, it's white, I know, but you may not be able to see it. But if it is that you said, okay, I have pumpkin and I can do this 3 times for the day, my half cup servings with breakfast, with lunch, and with dinner, fine. But don't find yourself overindulging again, just because it's what you have at the time, because you are anxious to get the amount of vitamins and minerals in. Yes? So, food security, in terms of treating with that, by all means, go with home gardening. If you can, using short crops that will supplement until we can ride out this COVID experience, and not just for this, but even for beyond that, so that it really cuts the cost of providing for yourself and for your families.
Thank you very much, Ms. Pierre. Thanks very much to all our presenters in the first session. Thank you to our viewing audience for the questions, the stimulating questions. So we're going to move into session 2 now, which comprises two segments, ophthalmic manifestations and treatment of eye disease. And we're going to start off with our next presenter, Dr. Kyawa Clark, who is in his 6th year of residency in the ophthalmology postgraduate program at the UWI, St. Augustine campus. He also works full-time at the Port of Spain General Eye Clinic as a registrar, where he is involved in teaching and mentoring of medical students, nurses, and junior colleagues. Within this capacity, he aims to apply the knowledge obtained through training in the regional UWI program, as well as experience gained through his time spent at the Moran Eye Center, University of Utah, one of the top 10 eye units in the US. His plan after completion of the DM program is to pursue a fellowship in glaucoma with the aim to help tackle the #1 cause of preventable blindness in Trinidad and Tobago, glaucoma as well as the NCDs. Dr. Clark will now present on ocular complications of chronic non-communicable diseases. Over to you, Dr. Clark.
Okay, thank you very much. Good day to everyone, all our viewers. Today I'll be talking about the ocular complications of chronic non-communicable diseases. So for quite some time, we have known the connection between the eye and the rest of the body. Some people say the eye is the window to the soul. The Bible verse Matthew 6, verse 22-24 makes mention of the eye being the lamp of the body. And if your eyes are healthy, your whole body will be full of light. But if your eyes are unhealthy, your whole body will be full of darkness. So our main objectives here today will be to discuss and give an overview on how some of the more commonly known systemic chronic non-communicable diseases may impact the eye, primarily diabetes mellitus, hypertension, also known as high blood pressure, and elevated cholesterol. So diabetes can affect the eye in many ways, but the most frequent and concerning is called diabetic retinopathy. Diabetic retinopathy is the 4th most common cause of severe visual impairment worldwide, and the 3rd most common cause of blindness in Trinidad and Tobago and Barbados, based on 2 population-based studies, NEST and the Barbados Eye Study. And which is particularly important, it's the leading cause of blindness among working-age adults, and that is a major public health issue. So how does one get diabetic retinopathy, or how does it affect the eye? Well, the high levels of sugar in the blood can cause damage and changes to the vessels all over the body, including the eye. And this causes the vessels to become weak and leaky, resulting in leakage of fluid into the retina. Once enough damage has occurred to the affected vessels, they close, resulting in reduced blood flow and oxygen to the retina. In an attempt to correct this, as the body always tries to fix itself, the eye will send out signals to try to grow new vessels to bring more oxygen. But these new vessels don't have the same integrity as your regular vasculature, and this can lead to further complications and eventually lead to vision loss. The mechanism for vision loss varies. It can be leakage of fluid into the retina at the main seeing area called the macula, as seen in the first image here. Right, and you can see the fluid collecting in the macula. Or it can be lack of oxygen, which can cause the vital retinal tissue to die or not function effectively. Or it can be new vessel formation, which can lead to the following complications, such as vitreous hemorrhage, where it is bleeding into the jelly of the eye, blocking the vision. Tractional retinal detachments, where the retina is pulled away from its origin. Or neovascular glaucoma, where these new vessels start to grow into the drainage channels of the eye, leading to elevated pressure and loss of vision. So diabetic retinopathy, the main symptoms you would see or get will be distorted images, floaters, and dark spots in the vision or loss of vision. But this is mainly seen in advanced disease, as generally there are no symptoms in early disease. So who gets diabetic retinopathy? Well, those who have had diabetes for a very long period of time with poor control. And other associated risk factors include high blood pressure or hypertension, elevated cholesterol, poor pregnancy, kidney disease, smoking, and obesity, as mentioned by some of the previous speakers. Aside from the loss of vision associated diabetic retinopathy, the retinopathy is actually a small view of the effect elevated blood sugar is having on the entire body. And so basically what we're seeing happening in the eye is actually happening everywhere else. And this has been picked up in several medical studies, which noted an association with kidney disease, stroke, heart attack, and cardiovascular-related death, as seen here. About 90% of patients with kidney disease, 90% of patients with retinopathy and type 1 diabetes have associated kidney disease, and up to 40% of patients with type 2. But diabetes does not only affect the retina and cause retinopathy, it can affect other parts of the eye. In actual fact, it can affect any part of the eye. These include the lids, in terms of increased infections in the lids, the cornea, where the cornea can repeatedly slough, causing severe pain. It can affect the lens in the form of cataract, the orbit in terms of increased risk of infections in the orbit, and nerves. Now, diabetes in nerves, it can affect the nerves controlling the eyeball movement and raising the lid, as seen in these images above. But this effect is not usually permanent and can improve with time. And it can also affect the optic nerve, resulting in vision loss. Diabetes can also increase the rate of cataract formation, and this can cause problems with vision, as most people know, and also can prevent the doctor from evaluating the eye, as Dr. Mutalal was talking about, for diabetic retinopathy. And if it's severe enough, can even prevent treatment. So moving on to hypertension. This has been an implicated risk factor in many vascular diseases. And like diabetic eye disease, what we see in the eye is an extension of what is happening in the rest of the body. Hypertensive retinopathy can be divided into 4 grades, of which worsening grade worsens with the severity of high blood pressure. The high blood pressure, like diabetes, results in damage and change to the arterioles, resulting in stiffening. These stiff arterioles can then compress veins at the crossings, as seen here, where the veins and the arteries cross. If severe enough, it can cause alteration of blood flow, blockage of blood flow, and again, starvation of oxygen, which can affect both the retina and the optic nerve. If it's severe enough, blockage of blood flow can result in a retinal vein occlusion, another major complication of hypertension, diabetes, and high cholesterol. This can be in the form of a central retinal vein occlusion where the main retinal vein is occluded, or a branch retinal vein occlusion where the blockage is one of the smaller branched veins. This is what it tends to look like when we're looking at the back of the eye. In the photo on the left, this is a branch retinal vein occlusion. As we can see, the bleeding into the retina inferiorly here, because there's a blockage around this area here where the artery is crossing the vein. And in a more severe case where the central retinal vein is occluded, we're seeing the bleeding and blood throughout the retina. So how do people lose their vision with retinal vein occlusions? Well, it's quite similar to how people lose their vision with diabetic retinopathy. Vessel leakage, oxygen starvation, and new vessel formation and the resultant complications. So how do we know that retinal vein occlusion has occurred? You may have sudden, painless loss of vision. You may have distorted vision, especially if there's swelling at the main scene area. Blind spots may occur in the vision, or peripheral vision loss. And then finally, the third main contributor here to a non-communicable disease and the eye, high cholesterol. And this is one which people tend to not take very seriously, but can have serious implications. This condition that we see here in the photos is called xanthelasma. And high cholesterol may sometimes present itself as these yellow lesions on the skin around the eyes. And half of these people who present with this may have elevated cholesterol. But this is not particularly sight-threatening. The more severe association with elevated cholesterol is carotid occlusive disease. Essentially, this is when cholesterol plaques form in the major vessels to the head and neck. As seen in these diagrams, these vessels from the major blood supply form the major blood supply to the eye and to the brain. These cholesterol plaques narrow the space in the vessel, resulting in decreased blood flow to the brain and the eye. And this may be noticed as loss of vision with change in position of the head. The plaques may also rupture, resulting in blood clots or a piece of the plaque breaking off. This clot or plaque fragment can flow to any of the vessels downstream and block them, and this is called an embolus. So when an embolus occurs, it may actually block the main artery or one of its branches to the retina, and this is called a central retinal artery occlusion. And this will stop all flow to the retina. If this flow is not reestablished within a couple hours, there's irreversible damage to the retina, and that vision loss will be permanent. Sometimes there are smaller blockages which may happen before, And you may see some warning signs, such as flickering of the vision or intermittent vision loss, seen as a curtain coming down over the vision, lasting a few seconds to minutes. As you can see in the image here, we're actually seeing small white lesions within the blood vessels. These are actually the cholesterol plaques in the retinal vessels. And finally, the embolus can actually go to the brain, resulting in a stroke, which most people commonly notice with twisting of the face or weakness on one side. But if the stroke actually occurs in an area which services vision alone, they may actually present with loss of vision, either on one side, or rarely if the stroke is on both sides, it can lead to a condition called cortical blindness, where the eyeball is fine, the globe is fine, the retina is fine and working, but the area of the brain required to see is not working. So, in summary, NCDs or non-communicable diseases are major contributors to mortality in the Caribbean. Diabetes is a common cause of avoidable blindness. Diabetes is the most common cause of vision loss in the working age group, and together with hypertension, high cholesterol, have been implicated in many causes of vision loss. And diabetic retinopathy and hypertensive retinopathy are not isolated, but are a sign of a larger systemic problem. Thank you very much for the insight.
Thank you very much, Dr. Clark. Thank you for highlighting the signs of the ocular complications for us and pointing out the things that we need to look out for. Ladies and gentlemen, please remember to pose your questions in the chat sections of the forums that you are on, whether it be UE TV or Facebook Live. Our presenters will take the questions at the end of the session. So our final presentation in this section is going to look at treatment of eye disease caused by NCDs, and Dr. Shari Cadogan will be our presenter. Dr. Cadogan is a Year 6 resident in the UWI DM Ophthalmology program at the Cave Hill campus. She is the chief resident in the Department of Ophthalmology at the Queen Elizabeth Hospital in Barbados. She has an interest in retinal vascular disease and has conducted research in diabetic retinopathy screening in Barbados. Her research has aided the development of a national diabetic retinopathy screening program. Currently in its infancy, Dr. Cadogan continues to be a major player in the development of the national screening program. Shari has spent 6 months at the Department of Medical Retina of the academically acclaimed University of Toronto, where she worked with several world-renowned specialists in the field. She plans to pursue a career in vitreoretinal surgery. Dr. Cadogan will now share with us on the management of the ocular complications of chronic non-communicable diseases. Over to you, Dr. Cadogan.
Hi, good afternoon, and thank you for that introduction. And I'm very happy to be taking part in this symposium. So I'll be looking at the management of ocular complications of non-communicable diseases. And essentially, I'll just touch on a few of the diseases that Dr. Clark has mentioned already. So we'll start with diabetic eye disease first, specifically diabetic retinopathy. So when it pertains to the management of diabetic retinopathy, there are several stages in its management. The first I'm going to speak of is prevention. This involves preventing yourself from getting a disease in the first place. So as we know, prevention is better than cure, and controlling blood sugars, blood pressure, and cholesterol can stave off, and in some cases reverse these eye complications. And as we have spoken before during the symposium, healthy lifestyle through diet and exercise, as well as checkups with your primary care physician. The other aspect of it is secondary prevention. This involves detecting a disease early and preventing it from getting worse. How this is accomplished in diabetic retinopathy is through screening. So if you have diabetes, it is important to have a dilated eye examination at least once a year by an eye care professional. If you're a type 1 diabetic, it's advised that this is done 5 years after the time you were diagnosed. And if you were type 2, it's advocated that you have it done at the time of diagnosis. Because many times with type 2 diabetics, you don't know when you first had a disease, you just know when you were diagnosed with it. You could have had it for many months and sometimes even years, without knowing. So when retinopathy does develop at all stages of the disease, the first treatment is control of blood sugars, blood pressure, and cholesterol. In the early stages, once you control these factors, they have been found to reverse changes. And in addition to that, your ophthalmologist will also schedule more frequent appointments to monitor for progression. So then we move on to tertiary prevention, and this involves improving your quality of life to reduce the symptoms of a disease you already have. So in essence, to reduce the morbidity of it. So how this is done for diabetic retinopathy, we have several treatment modalities available to us. The first I'll speak about is laser therapy. This can either be done in a scatter form, focal, or grid, depending on the effect you're trying to achieve. So focal laser, as seen on the diagram on your right, means that we target specific blood vessels which are diseased, and we apply laser treatment to those. In the grid treatment, essentially you create a grid, and in the scatter laser is as it sounds, we just scatter laser burns all around the back of your eye. And like I said, you do it based on what you're trying to achieve. So we can do focal treatment if you're trying to stop blood vessels from leaking and reduce the swelling that is causing. We can do grid as well to improve the oxygen supply to a particular area of the retina. And we can do scatter if you have formation of these abnormal blood vessels on the retina, as what Dr. Clark would have spoken of. So in essence, lasers are used for the treatment of macular edema or swelling at your macula, which is the area that controls your center vision, as well as for the treatment of abnormal blood vessel growth. And just to give you an insight into what laser involves, you're positioned as we see in the diagram on the right, and it involves shining a laser light into your eye. A special lens is placed on the eye, which keeps your eye alert, as well as focuses the laser on the retina. This can be done in the clinic and is a relatively painless procedure. The other treatment modality that we employ for diabetic retinopathy is that we inject medications into the back of your eye. It can either be a steroid or a special group of medications called anti-VEGF or anti-vascular endothelial growth factors. And what these drugs do, they can reduce the inflammation in the eye, which is a component leading to leaking and swelling at the macula, And they can also block abnormal blood vessel growth, which can cause leakage and several other complications. So therefore, it's used in the treatment of macular edema and in some cases of abnormal blood vessel production, as seen in diabetic retinopathy, but less commonly so. How this is done, once again, it can be done in the clinic setting or basically wherever your eye care physician decides to do the injections. Anesthetic is applied to the eye that's being treated. And we literally just inject through your eye, primarily through the white part of your eye or your sclera. In this type of treatment, multiple injections are often required, usually at the discretion of your doctor and based on the severity of your disease. So these can be given every month to every 2 months or every 3 months even. In terms of surgery for diabetic eye disease, we employ surgery for cataract. We touched on cataract earlier. So initially you can be tried with glasses, and if glasses no longer works, then you would require cataract surgery. And I'll just give you a brief overview on how we do cataract surgery. So most commonly, it involves making a small cut onto the surface of your eye. And this is done at the junction of the colored part of your eye and the white part of your eye. An instrument is then placed into the eye, which breaks the cataract into smaller pieces and then takes them out. That leaves a bag behind where your cataract was. And then we inject an artificial lens to sit in that bag. And that is what helps you to see, and it can stay there for the rest of your life. Other surgeries that we perform can be done for complications related to diabetic retinopathy. We touch on vitreous hemorrhage, which is essentially just a large bleed at the back of your eye. And detachments where you have scar tissue, and they essentially pull the tissue of the retina away. This surgery is a little bit more involved in cataract surgery and carries slightly more risks. And in this particular surgery, the surgeon enters the back of the eye. If you have a retinal detachment, the scar tissue that's causing the detachment is removed. And then a substance is put in the eye to then keep the retina flat afterwards. And this can either be a gas or it can be an oil. If you have a vitreous bleed, however, the surgery is a little bit more straightforward, where the blood is simply extracted from the back of the eye. We also spoke about diabetes-related nerve dysfunction. And as Dr. Clark mentioned, this doesn't only occur in patients with diabetes, but high cholesterol and high blood pressures are also risk factors. Luckily, this tends to be self-limiting, and after 3 to 4 months, you can expect normal eye movement. In a subset of patients, of course, regressive, they can have issues such as double vision, difficulty walking upstairs, sometimes they miss objects, and it can be very troublesome. So what we can do to alleviate that, you can have special prisms which are placed in your glasses to reduce that double vision. We can also inject Botox to relax the muscles in the eye, because essentially when the nerve is damaged, it paralyzes the muscle that it supplies, so the eye jumps in the opposite direction. What we do with the Botox injections, you inject the Botox into the opposing muscle, and that helps to straighten the eye up. So we'll go to retinal vein occlusions next. And please note, there is no cure for retinal vein occlusion because a vein that is blocked cannot be unblocked. But the aim of treatment is to treat any of the complications that can threaten your vision. So the treatment modalities are quite similar as they were for diabetic retinopathy. We can inject drugs, the steroids, and the antivascular endothelial growth factor. And in addition to injecting, there are also implants that can be injected into the back of the eye, which can last several months, up to 3, sometimes 6 months. They just release small amounts of the medication over a period of time. We can also perform grid laser, and this is done to improve the oxygen flow to your macula. And scatter laser, as you mentioned before, can also be done. In terms of neovascular glaucoma, this is where you have abnormal blood vessels being produced, and they cause your eye pressures to go very, very high, which is slightly different to the traditional glaucoma that we're accustomed hearing about. So this is a possible complication of all the before mentioned conditions. And unfortunately, when you develop this, your visual outcome tends to be pretty poor. So the treatment for this is surgical and non-surgical. So non-surgically, we can perform scatter laser to treat the abnormal blood vessels once again. And we can also give medications to reduce the eye pressures. These can be in the form of eye drops and sometimes oral medications. And because pressure goes up so high, it's usually a very painful disease. So in addition to that, we can give steroids to reduce some of the inflammation that accompanies this neovascular glaucoma. And there's also a special type of drop which can reduce the spasms within the eye that cause the pain in the first place. In terms of the surgical management, the surgery is aimed at reducing the eye pressure. So not much can be done to preserve vision, but we can reduce the eye pressure and reduce the pain. So in terms of the surgeries that are done, there's one called a trabeculectomy. Essentially, the fluid flows through the front of your eye, and because of the neovascular glaucoma, there's something that's blocking that fluid from flowing the way it should. So trabeculectomy essentially involves creating an alternative channel for the fluid to drain from the eye, thereby reducing your eye pressure. Alternately, you can put a tube, which you can see in the diagram illustrated on your right, and the yellow arrow is pointing at the tube overlying the brown part of your eye. And when that tube is implanted, that can also allow for fluid to exit the eye. Additionally, laser procedures can be done to modulate the tissues that produce the intraocular fluid as well. In cases of neovascular glaucoma, when the eye becomes blind and painful and treatment becomes ineffective, we can do an enucleation. And all that means is we surgically remove your eyeball and we put a prosthesis in. And as you can see in the diagram, this lady had an enucleation, and with the prosthesis, it looks almost normal. Alternately, alcohol can also be injected into the back of the eye, into the back behind your eyeball. And what that does, it destroys the nerves which cause the pain sensation. So we'll touch on high cholesterol and the effects of high cholesterol, which is the central retinal artery occlusion. So when it comes to retinal artery occlusion, it's almost like you're having a stroke or a heart attack, but in your eye. And basically, time is vision. And for treatment to be most effective, you need to seek medical attention within 4 hours after the onset of symptoms. Unfortunately, with central retinal artery occlusions, or artery occlusions in general, the outcomes tend to be very unpredictable. And the worse your vision is at the onset, the worse the final outcome is going to be. So how do we treat it? We can either dislodge the clot or dissolve the clot. Some techniques that have been employed to dislodge the clot are essentially just move it from the area that is blocking, would be hyperventilation. And this is with a substance called carbogen, which is a mixture of oxygen and carbon dioxide. And what those two gases do, they dilate your retinal arteries. So it helps the clot to move a lot further down into an area where the visual consequences wouldn't be as severe. We can also lower your eye pressure by removing fluid from your eye, or by giving medication, or massaging the eyeball, which helps fluctuate the eye pressures. And these changes in eye pressures are thought to also aid in dilation of the retinal arteries and dislodging of the clot. Also, in terms of dissolving the clot, however, we have a special type of medication. It's almost like a clot busting medication called TPA, or tissue plasminogen activator. And this is injected into the blocked artery. Either it can be injected through your vein, or a special type of radiologist actually injects it into one of the arteries in your brain, which eventually goes to your eye, and essentially it dissolves the clot. Also, importantly, we must control our cholesterol and our blood sugar. In terms of hypertensive retinopathy, no specific treatment is required for this, but management of your blood sugar is all that's required. So in summary, prevention is better than cure. Good blood pressure, blood sugar, and cholesterol are paramount in preventing these ocular complications. When these problems do develop, however, lasers and eye-injected medications are key treatment options. Surgery is only required in cases of cataract and complications related to these retinal vascular diseases, as well as uncontrolled eye pressures. And you must note or remember that some of these complications can lead to irreversible blindness.
Okay, thank you, Dr. Cadogan. Thank you for sharing some very insightful overviews on the management options for ocular complications of NCDs. And thanks to all the presenters in this session too. We're now going to go to the question and answer segment. And so we are reminding our viewers that they can place their questions in the comment box for Facebook Live and uitv.org. And we will take your questions to the presenters for feedback. So the first question goes to Dr. Clark. Does diabetic retinopathy run in families? Is it that if your relative went blind from diabetes, does that mean you are at risk of also going blind? Dr. Clark?
Hi, thank you. Very interesting question. So in actual fact, diabetic retinopathy in itself doesn't run in families. It's the diabetes that runs in the families, and it's the risk factors associated with diabetes, hypertension, and high cholesterol, among others, which would actually put you at risk for developing diabetic retinopathy. So if you have a relative who does have diabetic retinopathy and went blind, but you don't have diabetes, no, there's no increased risk of diabetic retinopathy. But if you did have a relative who has diabetic retinopathy and you do have diabetes, and you don't have your blood sugar controlled or your blood pressure controlled or your cholesterol controlled, then yes, you are at increased risk of going blind from diabetic retinopathy.
Thank you, Dr. Cadogan, for shedding some light on that. How successful, question since Dr. Cadogan, how successful is cataract surgery? Sorry, not Dr. Cadogan, my apologies. To Dr. Clark. Back to Dr. Clark. If one eye is affected by the conditions that you've described, will the other eye automatically be affected? So Dr. Clark.
Well, it depends. When we're talking about diabetic retinopathy and hypertensive retinopathy, we must remember that these are actually part of a systemic problem. And usually when it's part of a systemic problem, it will affect both eyes almost equally. That being said, they have conditions associated with diabetes, like retinal vein occlusion and retinal artery occlusion, which generally will affect one eye, but the other eye may be at risk if you do not control the risk factors which predispose you to the condition in the first eye.
Thank you, Dr. Clark. Dr. Cadogan, I have two questions for you. Many supplements, so the the question is, many supplements are available on the market claiming to improve your vision if you have cataracts or other eye diseases. Do these work for any of the conditions you have mentioned in your presentation?
In terms of cataract or any of these diabetic or hypertensive related complications, these supplements boast to improve your vision or reverse it. But for cataract, for instance, the only way you can treat a cataract is, like I said, by glasses or surgery. So these tend to be very false. But there are supplements that can improve your vision, but not for these diseases, primarily for things like age-related macular degeneration, where it has been shown that zinc, copper, vitamin C, vitamin E, those can help reduce your reduce poor visual outcomes.
Thank you. Thank you, Dr. Kudogan. And the other question to you is, how successful is cataract surgery?
Well, cataract surgery is one of the more successful surgeries generally that we perform on the eye. We really only have statistics for the United States a lot of the time, but success rates have been cited to be between 95 to 99%. Things that can affect it, however, that if you were to wait until your cataract was quote unquote ripe, where people tend to present with very large cataracts, which are more prone to having complications intraoperatively. But around 95 to 99% very successful.
Thank you. Thanks very much for that, Dr. Kadogan. We do have a couple questions which we didn't get to from the first session. So the other presenters, I'm going to bring you back in now just to answer a couple questions. And the first one goes to Dr. Motilal. What recommendation, Dr. Motilal, can you give to persons that work long hours using their computers for hours and hours at length? How can they protect their eyes?
Yeah, very interesting question. And Ms. Ivy, you should be aware of this because you recently shared some vital information to our faculty on this very matter. So I'm happy it has come up. So of course, what I could quote is your recommendation, right? In terms of when a person have to be on their screen for long periods of time. So if I remember correctly, your recommendation, it was 20-20-20, right? So every 20 minutes, you should take a little break, stare ahead for at least 20 seconds to something about 20 feet apart, at least to give your eye just more or less a kind of break. But it's real. Tiring of the eye and strain is real, especially you have to sit in front of computer screens for long periods of time. I usually would tell some patients, I mean, I would have even some people complain that, you know, they might get headaches or they might feel just emotionally tired when they're sitting in front of the screen for long periods of time. So it's not only the effects on your eye, but taking breaks at regular intervals definitely helps with it.
Thank you, Dr. Motilal. Yes, 20-20-20. 20 minutes, after every 20 minutes, you look away to a distance of about 20 feet and you rest your eyes for 20 seconds and then you can resume. So you can do things like setting a timer on your computer or on your phone that you just alarms and it reminds you. Thanks, Dr. Motilal. Mr. McTeer, just another question coming back to you, and you may have touched on it in your presentation and in the previous questions, but I'm just going to ask it again, just in case persons need clarification. What type of exercises would you suggest that be performed to stay active while at home? What are some key ones you would suggest to the viewers for them to perform at home to stay active?
That's an excellent question. Firstly, you really, to put it into context, you want to perform exercises that are referred to as compound exercises, which are defined as exercises whereby a person uses multiple muscle groups to perform one movement. What that helps to do is, one, it helps to burn calories a little bit more. It allows you to work more muscles in a short space of time, so it increases the efficiency of your workout. Also, it helps to increase the cardiovascular rate. It helps in terms of coordination and balance. It helps to promote joint stability and the mobility of the joints much better. And normally, compound exercises allow for you to be able to utilize weights that are lighter. All right, and even if it is you go heavy with them, normally they are safer on your joints. Right now, examples of compound exercises. The simplest one is a squat. Okay. You have lunges as well for your legs. You could do stair climbing. And what it is you can do, if it is you have the range of motion, you could actually skip stairs to go up. Some people may go as far as running stairs or jumping from step to step on staircases. Those are simple exercises that you can do. Deadlifts as well, the lifting of objects from the ground to a standing position. You normally it's suggested that you use your legs. So you bend the knees, you drop the hips, you pick up, you stand up straight. That works quite well, more or less the entire uh, the entire body in terms of multiple joints and multiple muscles. If it is you have the equipment to do so at home, or at least something that you could feel safe in pulling yourself up, you can do pull-ups, you can do chin-ups. If the area also provides that space, you could do dips as well. There are a number of different exercises that you can use just with your body weight as well that would give you the kind of exercise needed for strength as well as for cardiovascular endurance work. Other exercises like burpees and running on the spot, jumping jacks, jump rope, those are also excellent compound exercises that can be used for anaerobic endurance work and cardio work.
Okay. Thank you very much. Thanks very much, Mr. McTeer. So, ladies and gentlemen, we are going to close up the Q&A section, and we thank you for all your questions. And we're now going to invite our host, Dr. Murray, to give a brief summary and deliver the closing remarks. Over to you, Dr. Murray.
Thank you, moderator. According to the Pan American Health Organization, World Health Organization, 80% of blindness is avoidable, being either preventable or treatable. Chronic non-communicable diseases such as diabetes, high blood pressure, and high cholesterol are important causes of blindness and visual impairment. Making small and simple lifestyle adjustments to your diet can often go a long way towards maintaining good eye health and avoiding blindness. Moderate exercise, such as walking or jogging, 3 or more times every week, can have a beneficial effect on eye pressure. Lockdown and quarantine are not reasons to avoid exercise, and very efficient exercise can be achieved in a limited space with very limited equipment. The integrated eye care team, consisting of nurses, opticians, optometrists, and doctors, general practitioners, and specialists, work together as eye care professionals to preserve and restore sight. Current strategies for eye health include reducing preventable disability by providing access to screening, early diagnosis, treatment, and rehabilitation services. This year, the call to action for World Sight Day is Hope in Sight. This virtual public symposium focused on the effects of chronic non-communicable diseases on the eye and vision to raise awareness about these lifestyle diseases as causes of blindness. Primary prevention involves preventing yourself from getting the condition. Secondary prevention involves screening and early detection. And tertiary prevention involves treatment to minimize vision loss and maximize visual potential. The advice we offer here today is to have regular dilated eye examinations before your vision is affected. Prevention is always better than cure. Do not take your sight for granted. On behalf of the University of the West Indies, I wish to express sincere thanks to all our speakers for their interesting, informative, and insightful presentations. We are also grateful to the Trinidad and Tobago Association for the Blind and Visually Impaired, also known as the Blind Welfare Association, for their contribution to today's symposium. We especially acknowledge and thank Ms. Bonnie Rambajan, whose 6-year-old son Adam is blind, for writing a prayer, and to 14-year-old Jaden Vincent for reading the prayer via Braille. Thanks to our Dean, Faculty of Medical Sciences, Professor Terence Simangal, for his opening remarks, our Head of Department of Clinical Surgical Sciences, Professor Dilip Dan, our eye care colleagues, all eye care professionals who work to prevent avoidable blindness, and our moderator and Associate Dean Public Relations. We also wish to thank Marketing and Communications at the University of the West Indies, St. Augustine, and UETV for their contribution today. The University of the West Indies recognizes with appreciation our generous 2020 sponsors: Alston's Marketing Company Limited, AMCO, Unicoma Quartz Optical, Ferrera Optical Limited, the National Gas Company, Oscar Francois Limited, and RBC Royal Bank. And last, but by no means least, thanks to all the attendees, especially those who asked questions and participated in the discussions about eye health and vision. Please have an enjoyable World Sight Day 2020. Back to you, moderator.
Thank you so much, Dr. Murray. So, ladies and gentlemen, we are now at the end of our symposium. I trust the presentations and the summaries have provided you some hope, insight on this observance of World Sight Day. Thank you again. You have been a wonderful audience. Please remember, we are in a new norm. Please wear your mask, practice proper hand and respiratory hygiene, and keep your distance and be safe.